Radiosurgical treatment for epilepsy. Some patients have epileptic focus that are difficult to access or in irritant functional regions where surgery could result in irreversible language, motor, or visual impairment. The highly focused nature of radiosurgery allows sparing of adjacent tissues from the damage without surgical risk and permitting patients to return to full activity within 1 to 2 days. The preclinical animal findings suggest that reduction of seizure activity after radiosurgery does not require necrosis or concomitant functional loss of treated neurons. Anti-epileptic efficacy of radiosurgery is dose-dependent, with a dose of approximately 25 grays being required to induce a therapeutic anti-epileptic effect, and the potential full histologic and other toxicity may require several months to fully develop. The first radiosurgical treatments for epilepsy were performed by Talleyrand in the 1950s. Talleyrand reported on the use of the radioactive yttrium implants in epileptic patients with mesial temporal lobe epilepsy without space-occupying lesions, and showed a high rate of seizure control in patients with epilepsy confined to the mesial structure of the temporal lobe. In 1980, Illuma demonstrated the idea of the use of the focal irradiation for the treatment of temporal lobe epilepsy based on the preliminary reports. Clinical experience of the use of the gamma knife surgery and linac-based radiosurgery in arteriovenous malformation and cortico-subcortical tumors revealed an anticonvulsive effect of radiosurgery in the absence of tissue necrosis. Until the 1990s, curative epilepsy surgery was limited to open microsurgery, with which abnormal epileptogenic tissue was physically removed. Regis and colleagues initially pioneered the gamma knife surgery technique in the mid-1990s and reported clinically effective amelioration of seizures with minimal morbidity. A recent prospective multi-center European study evaluating gamma knife radiosurgery for medial temporal sclerosis showed comparable efficacy rate up to 65% for reduction of seizures by conventional microsurgery and radiosurgery after 2 years of follow-up. One of the advantages of radiosurgery is its potential for relative preservation of memory in comparison with open resection. Open surgery for temporal lobe epilepsy entails risks of significant verbal memory impairment ranging from 10% to 60%. Radiosurgery also has some effects on verbal memory, although this is largely limited and has shown signs of improvement over time. Using the Wechsler Memory Scale and the California Verbal Learning Test, significant verbal memory impairment was seen in 25% of dominant hemisphere surgery patients and in 7% of non-dominant hemisphere surgery patients, for an average of 15%. The patients should be able to understand the limits and constraints of radiosurgery very well. In our opinion, the most important selection parameter for gamma knife surgery is the demonstration of the purely mesial location of the epileptogenic zone. Another good candidate for gamma knife surgery is the patient with proven MTLE who has had a surgical failure because of insufficient extent of resections. Overall, the best candidates are young patients with moderately severe epilepsy, socially well-adapted people with a high functional level and quite a high risk of memory deficit with open surgery, such as MTLE on the dominant side with a subtle hippocampal atrophy and slightly preoperative deficit in verbal memory. Hypothalamic hamartoma. Hypothalamic hamartomas are rare congenital heteropic lesions that are intrinsically epileptogenic when closely connected to the mammillary bodies. Patients classically experience gelastic seizures during the first years of life. In more severe forms of disease and epileptic encephalopathy characterized by drug resistance, various types of seizures with generalization, including drop attacks, cognitive decline, and severe psychiatric comorbidity develop in affected patients during the following years. Usually, the seizures begin early in life and are often particularly drug resistant from the onset. Commonly, the seizure semiology suggests the involvement of temporal, frontal regions and the phenomena of secondary epileptogenesis. The natural history is unfavorable in the majority of patients because of behavioral symptoms and mental decline, which occur as a direct effect of the seizures. Interestingly, in our experience, reversal of these behavioral symptoms after radiosurgery seem to begin even before complete cessation of seizures and appear to be correlated to the improvement in background electrophysiological activity. It's the author's speculation that this continuous discharge lead to the disorganization of several systems, including the limbic system, and that their disappearance accounts for the improvement seen in attention, memory, cognition, performance, and impulsive behavior. In these cases, radiosurgery's role in reversal of the behavior symptoms may be as or more important than its effect on decreasing seizures occurrence. Consequently, we consider it essential to operate on these patients as early as possible, whatever the surgical approach being considered, either resection or radiosurgery. Historically, those symptomatic hypothalamic hamartomas requiring treatment have been treated with resection versus disconnection, although these approaches carry with them several significant risks. Symptomatic epilepsy-related hypothalamic hamartoma is observed only with medium to large sessile lesions that are broadly attached to the tuber cinerarium or mammillary body, and microsurgical resection in this critical area is associated with significant risk for oculomotor palsy, hemiparesis, and visual field deficits. Radiosurgery, as is the case in mesial temporal sclerosis, provides a minimal invasive alternative to traditional open resection or disconnection of the hypothalamic hamartomas. It's been studied aggressively for determination of its safety and efficacy. Regis and colleagues published in 2000 the first series of hypothalamic hamartomas treated by gamma knife radiosurgery, and they retrospectively analyzed these results of radiosurgery in a multi-centered study of 10 patients and found all improved, with 50% cured and no adverse effect except for one patient with poikilothermia. The promising results of Marseille group led them to design the first prospective trial, evaluating a surgical technique targeting the hypothalamic hamartoma through evaluation of 57 patients suffering hamartoma of the hypothalamus with severe epilepsy between 1999 and 2007, with preoperative cognitive deficits and behavior disturbance, and the relationship of seizure severity and anatomical type, as well as cognitive abilities, were characterized. The goal of the preoperative workup was to adequately select the candidates for inclusion in the study and to evaluate the baseline neurological and endocrinological functions. The endpoint was primarily to assess the efficacy in terms of seizure reductions, and secondary to evaluate the psychiatric and neurocognitive comorbidities. Regis and co-worker consistently used multi-isocentric complex dose planning of high conformity and selectivity. They also used low peripheral doses to take into account the close relation with optic pathways and hypothalamus. Median dose was 17 days between 15 days to 25 days. They paid special attention to the dose delivered to the mammillary body and to the fornix, and tried to tailor the dose plan for each patient on the basis of the use of a single run of shots with the 4mm collimeters. The lesion's volume median was 398 cubic millimeter, ranging between 28 to 1600 cubic millimeter. Patients were evaluated with respect to seizures, cognition, behavior, and endocrine status at 6, 12, 18, 24, 36 months after radiosurgery, and then every year. Follow-up of more than 3 years was available for 48 patients. The median follow-up was 71 months, ranged between 36 to 153 months, according to the Indian Epilepsy Surgery Outcome Scale. At the last follow-up, the rate of Indian Class 1 outcome was 39.6%, Indian Class 2 was 29.2%, Indian Class 1 plus 2 was 68.8% in all hypothalamic hamartomas, and 74% in hypothalamic hamartoma anatomical type 1, 2, 3, and Indian Class 3 was 20%. No permanent neurological side effect was reported, in particular no memory deficit. A transient increase of seizure frequency was reported in 8 patients with a median duration of 30 days. Because of the poor clinical prognosis of the majority of patients with hypothalamic hamartoma and the invasiveness of microsurgical resections, gamma knife surgery can be considered a first-line intervention for small to medium-sized lesions, especially type 1 to 3 associated with epilepsy, because it can lead to dramatic improvement in these young patients. The role of secondary epileptogenesis or widespread cortical dysgenesis in this patient needs to be evaluated further and understood to optimize patient selection and define the best treatment strategy. Cavernous malformations. These are congenital vascular malformation of the brain. They may cause hemorrhage and neurological deficit, but the most frequent presenting symptom is epilepsy. 40% of supratentorial cavernous malformation presented with medically refractory epilepsy. The epileptogenicity of these lesions results from the ongoing deposition of iron and blood products at the margin of the lesions. Gamma knife surgery treatment of cavernous malformation is a controversial topic, and only a few studies are available, with conflicting results concerning gamma knife surgery effect on protection from hemorrhage. The risk bleeding secondary to cavernous malformation is different based on the lesion location, and the low risk of clinical bleeding is associated with cavernous malformation located in cortical subcortical sites as opposed to deep-seated lesion. Therefore, the main indication for surgery in these lesions is frequently seizure control, and microsurgery is considered the best treatment in patients with intractable epilepsy. In some series, however, a beneficial effect of gamma knife surgery was also reported for seizure secondary to supratentorial cavernous malformations. Because gamma knife surgery is usually associated with minimal risk of injury to the surrounding non-target neural tissue, this technique could be a good alternative for this patient, particularly when the cavernous malformation is located in the brain region associated with high surgical risk. Stereotactic radiosurgery has been applied to the treatment of cavernous malformation for 2 primary reasons: prevention of the future hemorrhage and reduction of seizures. Though initial studies in the late 1980s and early 1990s showed high complication rates, more recent studies have demonstrated improved safety through this modality, and it has found greater application in the 21st century. The effect of radiosurgery on the future hemorrhage rate is controversial. Also, the trend has been growing in favor of radiosurgery with time and additional research. It has been theorized that hemorrhage naturally cluster in cavernous malformation and then taper off with time in their own. Thus, it's possible that the apparent reduction in hemorrhage frequency after radiosurgery is actually a result of this natural phenomena. Recent onset seizures and good correlation between symptoms and location of the cavernous malformation, usually lesionectomy is the best method. Epilepsy surgery strategy should be preferred for patients with a long history of chronic epilepsy in whom correlation of clinical and EEG findings are unclear. Surgery could aim to control epilepsy rather than to remove the lesion. The appropriate use or non-use of these criteria probably explain why the success rate for surgical excision of cavernous malformation varies between 20 to 80% in the literature. The prognostic factors depend on the type of the seizures. Better outcome was observed for patients with simple partial seizures than for those with complex partial seizures. Also, locations, poor outcome in the medial temporal region, good outcome in the lateral temporal region, excellent outcome in the central region. The morbidity was found to be low. Radiosurgical corpus callosotomy. Bendelital in 1999 were the first to introduce radiosurgical callosotomy with marvelous improvement for atonic and generalized tonic-clonic seizures without surgical or neurological complications. Afterwards, the promising studies published from the radiosurgical callosotomy show the safety and effectiveness, but in small groups of patients, either using anterior or posterior radiosurgical callosotomy. In Marseille group, all the callosotomy procedures are performed nowadays using the gamma knife. In general, callosotomy is widely accepted surgical option in appropriate selected patients as a palliative surgical procedure for intractable generalized epilepsies who are not a candidate for a focal resection characterized by injurious drop attacks and for refractory frontal lobe epilepsy that cannot be adequately localized. To conclude, prospective trials demonstrated that radiosurgery is effective, safe, and promising for medically intractable epilepsy associated with medial temporal epilepsy, hypothalamic hamartoma, cavernous malformation, and drop attacks. Radiosurgery may prove to be especially appealing in treating lesions near functional cortex or deeply seated lesions when open microsurgical resection might not be visible without significant morbidity. Determination of the epileptogenic zone, which is crucial to achieve reasonable rate of seizure cessation, requires specific expertise. Further prospective works remain necessary to study the huge impact of fine technical details on the efficacy and eventually toxicity of the procedures.